Well, good evening, everyone. Welcome to the International Women's Forum Connecticut November program. The International Women's Forum, or IWF, was founded 50 years ago and now connects more than 8,000 outstanding women leaders in 33 countries around the world. We are the only organization of this scale that builds significant relationships between women leaders across countries and careers. I'm Leslie Grossman, Program Chair of IWF Connecticut. This evening's program is focused on a critical issue that many of you or your family members are impacted by: Medicare changes that will take place in less than 2 months, which is why our Medicare experts have entitled this program, Medicare has reshaped the 2025 marketplace in wild ways. Today, we are delighted to welcome members of the IWF, not only from Connecticut, but also from forums around the country, including many members from New York and Chicago, as well as other forums. We're happy to have you all here today. And we're especially proud to have one of our foremost Connecticut members, a past president of our chapter or forum, who today serves on our program committee, who will be opening and leading today's program, Maura Carley. In addition, you received in the invitation all the bios of our healthcare experts who will be speaking, so you can refer to that to know more about them. And they will be answering any questions you have following the presentation. Please post any questions you have in the chat. If your questions are not answered within the hour we have set aside, our experts will stay on Zoom past the hour to answer them. Now, it's my pleasure to introduce Maura Carley, a leader in healthcare. Many of you already know her. Maura has more than 20 years of experience with large hospitals and health plans. She and her team have been advising and supporting clients for one purpose only: to protect them. They do this through their organization, Healthcare Navigation. And now it's my pleasure to turn the program over to Maura Carley.
Thank you, Leslie. Thank you for that lovely introduction. And thanks to all of you who have signed in to hear us tonight share information about Medicare with you. The way we will proceed tonight is I'm going to provide some background and history. Then I'm going to describe what is so different about the environment today and who will that affect. And then I'm going to turn the program over to Sarah Gravelin to talk about specific changes in Part D, and then to Eileen Wilson to talk about Medicare Advantage changes. And then two more colleagues, Susan Bruschi and Tricia Lutzo, will join us in the Q&A. It will be helpful when you enter your questions if you put your state of residence in, because some of us have specialized expertise in certain areas of the country, and it will help us decide who should take that question. So may we go to the next slide? I am going to condense the almost 60-year history of Medicare into a few minutes. And this should help people who are tuned in, who are not yet on Medicare, but need to learn a little bit more about it. And it will also give all of you an appreciation for how much healthcare changes, and Medicare changes too. That's why you need to know what's going on so that you can determine, should I do something, and know how to take the steps to do so. Now, we're not going into history prior to Medicare beginning. It launched in 1966 with Part A, which covers inpatient facility services, and Part B, which covers physician and outpatient medical services. And then if you go all the way to the right of the screen, you see 2006 Part D, outpatient drug coverage begins. So one thing I want you to keep in your memory is that it took us 40 years to implement an outpatient drug benefit. So we certainly, as a country, didn't rush into anything. Ever so briefly, let's just go through the history. Original Medicare A and B is structured with deductibles and co-insurance and co-payments. So private products called supplements or Medigaps developed quickly so that individuals could buy those and have additional coverage. I do want to mention, again briefly, the HMO Act of 73, the often forgotten act, because if you think back in history, the HMOs that existed in 73 were the very mission-driven nonprofit plans. And there was thinking, and this was part of the HMO Act of 73, that mandated that employers of 25 or more had to offer one of these HMOs if it was in their geographic area. That led to many more for-profit players saying, this is a field we should get into. And similarly, you had demonstration projects. This is what led to Medicare Part C, Advantage plans. But again, the thinking was, well, Medicare is a government-run program, so it must be inefficient. Let's get more private players into the field and offer an alternative, and maybe they will save the system some money. So then we fast forward, we're up to 2006. Part D begins, but with an abundance of caution. It's got a benefit structure that has what was referred to as the donut hole, the dreaded donut hole, which if you got into that part of the benefit, you had no coverage. It took us many years to close the donut hole, not until 2019. So we've approached drug benefits with great caution until recently. I'll just mention 2007, Part B became income indexed. 2011, Part D became income indexed. But remember, the population involved here tonight is not typical of the country. Only 5% of Americans pay these income index premiums. All right, so let's go to the next slide and talk about where we are today. Today, the vast majority of Americans choose between these two constellations of coverage. There are others. Some have Medicaid, retired military or on TRICARE. Government employees still tend to have the option of a rich retiree medical plan when they retire, but for private sector people, they too are likely to have either the retiree medical structured as an Advantage plan, Part C, that's opting out of Medicare. You can put your Medicare card away. You've enrolled in United or Aetna or whatever. They send you a card. Most Advantage plans include drug coverage, but not all. Or the other alternative for those with retiree medical is to have your employer refer you to a private exchange like Via Benefits, and you have a subset of these options because there's so many choices of plans, so many choices of Advantage plans and Part D plans and supplements, more than in our view is actually helpful. it just adds so to the complexity. And then, of course, you have people who don't have any type of retiree medical, who have often just a wide universe of options to select from, in addition to being on A and B. So let's go to what's changed. That's the next slide. So the Inflation Reduction Act of 2022, the important change is that it created an out-of-pocket maximum. And that never existed. So from 2006 through 2023, there was no out-of-pocket Part D maximum. If you got to the catastrophic level, which was triggered by spending so much money, last year it was $7,400, then for the rest of the calendar year, you had coinsurance that was supposed to be roughly 5%. So what we have now this year is an $8,000 out-of-pocket maximum. It didn't disrupt the Medicare marketplace in a significant way because largely because as a percentage of the population, there aren't that many people that have the extremely high drug costs. And some are covered in other ways through programs I mentioned, like Medicaid. But a dramatic swing in an out-of-pocket maximum from 8,000 to 2,000 did disrupt the marketplace. And we don't think that it was as anticipated as it might have been. I mean, think about it. If you have someone saving themselves from so high and out-of-pocket expenditure, additional funds, the system is going to be looking for additional funds from somewhere. And so premiums proposed were very significantly increased. And when the government saw that, they created this Medicare drug premium. It's supposed to be premium negotiation. No, I'm sorry. I'm on the wrong line. That's part of the Inflation Reduction Act of 2022, but it's not in effect yet. Down to the underlined Part D premium stabilization demonstration. This hasn't been well publicized, but it is a voluntary program that is estimated this year to cost $5 billion for 2025 to have Part D plans stabilize the premiums they're offering. Otherwise, without these subsidies, premiums would have soared. So what we have to worry about is that the demonstration was supposed to be 3 years, and now we have a new regime coming in January, and the Inflation Reduction Act was passed without a single Republican vote. And our history is that we enter tough times when then the other party comes into power and decides this is not how we want to handle this. So we don't have a prediction for you. We're trying to give you enough information so that you can understand that you should be looking at this. Some people have to because their plans have been eliminated or consolidated, but everyone should be looking at this closely a year from now as well. And it's not just people on Medicare. For example, my staff have a plan they can enroll in, but I have remained on my husband's plan, which is a large employer, and I have active group coverage. So I haven't had to enroll in Medicare, but and I should share with you, the government's term for people like me is the working aged, which I'm not very fond of. But anyway, If you know what a letter of creditable coverage is, it's a letter from your plan that says your coverage is as good as or better than Medicare Part D, and you're supposed to save those things to prove you had creditable coverage when you finally do go on Medicare. Well, I looked into our plan, and to my surprise, the out-of-pocket max for our drug coverage is $8,050, which is very unusual. The medical is $1,400. And so I was fearful we too would have to enroll in a Medicare Part D program, because how can you say a plan with an $8,050 out-of-pocket maximum is as good as Medicare, which now has a $2,000 out-of-pocket in 2025. And Sarah will show you plans that have maximums less than that. Long story short, I got in touch with some of my former colleagues at Kaiser Permanente, and I had my husband get in touch with his employer. And the actuaries have deemed our plan creditable. And apparently the government is allowing, this is according to real experts in the field of actuaries, allowing employers to use guidance, the employers and their actuaries, that dates back to 2009 to deem plans creditable. So it's a very strange environment, and everybody should just know, because we can't ever take the politics out of healthcare, that they should be really watching what happens over the next year or two. Totally different subject in some ways, but not others. Advantage plans are also affected by these changes because most of them include drug coverage. But Advantage plans, if you've been following the news, are under pressure from other fronts too. And honestly, some of them have been a little too greedy. You're not supposed to be paid for submitting claims for conditions that didn't require treatment or were cured. So in some ways, the payment reductions to Advantage plans were very, very legitimate. But the field is dominated now by publicly traded for-profit companies who are under a lot of pressure to have a profit. And when they don't feel it's worth their while, some of them are going to change their offerings, leave the market altogether. So we've had a long period of stability in these areas, and at least for the next several years, that is likely to not be the case. So I want to stop talking and turn this over to my capable staff, who are going to share with you much more specific information on how you look at these things yourself. Sarah?
Thank you. Hi, I'm Sarah Gravlin, Director of Client Operations at Healthcare Navigation. And tonight I'll discuss changes to Medicare Part D drug plans for 2025 in a little bit more detail than Maura was discussing. And we'll walk through a mock drug review, right? So you can see how to do this yourself. So the big change obviously is the $2,000 out-of-pocket max. We'll discuss how plans have reacted to that cap and how it works. So plans have reacted to this cap in different ways. Some have left the market, like Mutual of Omaha we see. Some have reduced the number of their offerings, like SilverScript. They offered 3 plans for years. Now they're going down to 1, only their SilverScript choice. Also United Healthcare, the AARP branded products, they've offered 3 plans for years. Now they're going down to 2. They've eliminated AARP Walgreens. I think this chart is good to share because it really illustrates how much premiums can vary, which not everyone is aware of. So if we're looking in the third column for 2024, we can see the lowest premium was WellCare Value Script at 50 cents a month, which It was amazing and staggering. But it goes all the way up to $155.80 with Blue Medicare RX Premier at the bottom. For 2025, premiums have increased for most plans in Connecticut, but we still have the same best in class, you could say. So WellCare Value Script is still the least expensive this year or next year, $12.40. Blue Medicare RX Premier is still the most expensive at $190.80, right? So a huge variance. If you're on inexpensive drugs, there's rarely a good reason to be on one of these plans that is $100 or more than $100 a month. But if you are on expensive medications, it may make sense to be on a more expensive plan. But then it may not, right? So it's really important for everybody to run their own drug review or get help with that, because it's really hard to just make a blanket statement on all of these plans. With the new $2,000 out-of-pocket max, we expected a reaction to that would be reducing formularies, right? So the formulary is the list of covered medications that every plan has. While we have seen some formulary reductions, they weren't really as dramatic as we thought. So for example, something that had maybe 3,400 medications in 2024 on their formulary now has 3,300. So not too dramatic. But the most important issue when you're selecting a plan is to validate that the drugs you take are on the formulary. Sorry, let's do the slide with the chart still. Thank you. To make sure the drugs you take are on the formulary and that they are covered without restrictions, if at all possible. And we'll look at how to do that again with a video we have coming up. So we have information here on Connecticut, but premiums actually vary by state, which not everyone knows. So WellCare Value Script is $12.40 next year in Connecticut. It's more like $38.70 in New York. It's nothing in Texas, right? So it's all over the place. We have seen similar premium increases in New York, but then in other states like Florida and Texas and Arizona, even in 2025, we continue to see plans that have no premium or more modest premium increases, or even some plans with dramatic decreases in their premium. So again, just trying to highlight that there's a lot of variability and you need to run your drug review, right? We can go to the next slide, please. So now we're going to discuss how the plans are structured with this $2,000 out-of-pocket max. So the deductible ceiling for 2025 is $590, right? That's set by the federal government. So the standard benefit design is that after you spend that deductible, you're paying 25% coinsurance, right? So that just means you're paying 25% of the cost of the medication at the pharmacy. The plan's picking up the rest. Once you've paid $2,000 altogether, you're done paying. All right, so this was simple enough to understand. So when we started running client drug reviews and seeing that the out-of-pocket costs at the pharmacy were actually much lower than $2,000 for some clients on some plans, we were very confused, and that put us down a little bit of a research rabbit hole. We can go to the next slide. I'll show you what we found out. So our research led us to this true out-of-pocket max. Now we're used to this term from previous years, but we didn't really expect this to be applied in 2025 anymore. And to be honest, it was pretty hard to find this information. It was not on the Medicare consumer site, nor was it on the carrier sites that have these sort of plans. So the true out-of-pocket max should probably be called the not so true out-of-pocket max, because it may mean that the beneficiary actually pays much less than $2,000 in drug costs if the beneficiary has an enhanced alternative benefit plan. So the way it works is if you have one of these enhanced alternative benefit plans, it's calculating the out-of-pocket cost at that 25% or at the cost you've actually paid for the medication, right? Whichever is higher. So that means if your cost share by the plan design is less than 25%, it's actually calculated as if you paid 25%, which is helping people get to the out-of-pocket max faster and to not actually ever pay $2,000. In Connecticut, 8 of the 12 plans offered, the drug plans, have an enhanced alternative benefit design. So if you're running your drug review and you see that your prescription costs are coming in at less than $2,000 a year, especially when you have expensive medications, just understand that's not a mistake. And the enhanced alternative benefit plan, it varies by plan, so it's more significant in savings for some plans than others. Again, you have to look at your drug review. Let's go to the next slide and I'll show you an example of this. So this is a drug review. We've taken screenshots from a client, and this person has one drug on the top, Aimovig, $772 a month. It's a big cost driver. And then she has 3 generics. So what's interesting here is for the Aimovig, she has a copay in this plan, and this is a United Healthcare preferred plan. So her copay is $47. Which is obviously much less than 25% of $772. So before we understood how this true out-of-pocket max worked, my assumption, what I expected to see, was that she would pay this monthly total of $89.79 every month throughout the year and never meet her $2,000 out-of-pocket max. But what we saw actually is on the next slide. So we see that in July, she stops paying, and she's actually only paid $628.53 at the pharmacy, but somehow has met her $2,000 out-of-pocket max. So again, how this is working is that the plan took 25% of the cost of Aimovig, which is about $193 a month, and including the other cost shares for other medications. And that's what was all added together. And once that met $2,000, she was done paying in July, right? So again, if you see this, it's not a mistake. It's not a glitch, which I thought it was, but it's not. So let's go to the next slide and we'll start talking about how to do a drug review. Just as a reminder, December 7th is your deadline to make a change if you want to for 2025. And if your plan's leaving the market, you definitely need to do this exercise. So first, you always want to run your drug review on the Medicare.gov website, okay? And you want to log into your MyMedicare.gov account or create one. And if you haven't created one, you really should, for a lot of reasons, but for what we're talking about today, it's just streamlines your future reviews because it remembers your pharmacies, it remembers your drugs. If you filled new drugs, it'll add, you can choose them from a list. So it's just very streamlined and much faster to do it in your MyMedicare.gov account. So obviously you want to have your list of medications, and also know that when you're running a drug review, you do not include Part B medications like vaccines. You're not going to include your diabetic testing supplies, and you're not going to include anything over the counter like supplements. So Michelle, if we can pull up that video, I will walk you through quickly, hopefully, how we can do a drug review. Thank you. Okay. I'm ready. Okay, so we're on the Medicare.gov site. We're going to find plans. Now, if you were enrolled in your account, it would know your zip code. Oh, no, sorry, no, you can go ahead. You know your zip code here. We're picking a drug plan. Fine, next. You can also do Advantage plan reviews here. Now, here it's asking if you need help with your drug costs. If you were enrolled in your own Medicare account, it would know this, but if you are not a low income person, this is not going to apply to you. So we can go on to the next step. Yes, we want to see our drug costs. And now you can add your prescriptions. We're just going to do one inexpensive generic just to keep this concise. But again, if you are logged into your own account, it's going to know that, which is very handy. Confirm your drug list. Now we want to add our pharmacies. I'd always suggest adding at least 2 pharmacies, just so you have a backup. And now what we have here is we are at the page where Medicare has taken all of our inputs, put it into the system, and it's generating an output. And it's going to list all of the plans available to you from least expensive to most expensive. And that's including the premium and the cost you're paying at the pharmacy. So we see it in Fairfield County, Connecticut, we have 14 plans. And we're going to go ahead and just pick the first 3 least expensive plans. Let's start there. So we're going to click the add to compare. Okay. So now we have a side-by-side comparison. We see the premiums, we see star ratings, we see a drug deductible, we see how many of our medications are covered, and we're seeing if our pharmacies are in network. Now, we don't want to just stop here and enroll in the cheapest plan. We're not done yet. You have to go to plan details because there's further information there that we need to look at. So this is where we're going to drill down and see monthly premium or monthly cost breakdowns at the pharmacy. We're going to see, again, our networks. Are they preferred in network pharmacies or just in network? What's the cost difference at these pharmacies? That might help you make a decision about where you want to fill your medications. And then we really have to click on find more, view more drug coverage. Because here we're going to have this very helpful table that has information about how our medications are covered and if there's any restrictions, right? So you want to know before enrolling in a plan, is there prior authorization for my medication? What are the quantity limits? And is there step therapy? Now, prior authorization isn't usually a big deal. Step therapy should be avoided at all costs. With step therapy, it means that that drug plan is only going to cover your medication if you take something else that they want you to take first and prove that it doesn't work. So people hate this. And it would be very frustrating to enroll in a plan not understanding that you have to go through this. There was an option to enroll in something else that did not have that requirement, right? So that's why we really have to go in here and look at the details. Then we can go ahead and look at the star ratings. We want to see 3+ stars if we can, but we want to go in here too and see exactly what the plan is doing well and what they could improve on. So now if we wanted to, and this is the plan for us, we can select enroll, right? And if we are in our enrolled in our Medicare account, it's going to have all of this information ready to go for us. If you're not, you can put it in here. So you can enroll through the mymedicare.gov account. You can also do it directly through the carrier. You should be aware that if you are enrolling on the Medicare.gov site, there's no ability to put payment information in. And some people, if they want to do that at the outset, should likely defer to that carrier site to enroll, right? So we can go to the final slide for me, Michelle. Thank you. So Part D, drug review takeaways. Create your account at mymedicare.gov for the streamlined reviews and enrollments. Verify your medications are on the formulary and understand restrictions, if there are any, again, prior authorization or step therapy. If you have a medication that nobody covers, that's going to be a formulary exception process, which is more intense than prior authorization and perhaps step therapy. And there's usually a good chance of those going through as long as it's an FDA approved diagnosis and you're not requesting a brand as a preference, right? If there's a generic available. You want to understand the cost share differences between using the in-network pharmacy or a preferred pharmacy or a mail order pharmacy. And that might guide your decision-making on where you fill your medications. As far as enrolling, again, Medicare doesn't take payment information when you're enrolling in these plans. So if you want to set up auto pay from a checking account at the time of application, you should defer to the carrier site to try to do that enrollment. Not all of them take that information at the outset, but most do. But if you prefer to receive an invoice and then set up auto pay later or handle that however you want, I would say do your enrollment on medicare.gov. You are able to have your Part D premiums withheld from your Social Security payment, and a lot of people choose to do this, but we just always recommend people do that with caution. because sometimes for whatever reason, this just doesn't work. So if you're going to do that, you really need to set an alarm in your calendar to check that sometime in late February or early March that this payment has already started to happen, because you have a 90-day grace period with drug plans to make your premium payments. And if they are not paid in 90 days, you will be terminated. And we have had clients be terminated for that exact reason, because they had a false sense of security regarding their premiums being paid from Social Security. Okay. And finally, a lovely thing about having that mymedicare.gov site is you can track your enrollment. You can see when you are enrolled in your new plan. That usually takes about a week. And Medicare also will terminate your former plan for you. So it's usually pretty seamless. So that was it from my part, talking about drug reviews in part D. So now I want to introduce my colleague, Eileen Wilson, who's going to talk to us about Medicare Advantage plans.
Hi, everyone. I'm just trying to get my video started because it is not allowing me to do that. But in the interim, we can get started. Okay, so here we go. Beautiful, wonderful. Okay, so my name is Eileen Wilson, and I am the Director of Client Services here at Healthcare Navigation. And I'm here to talk to you about Medicare Advantage plans, also known as Part C. Medicare Advantage plans are an alternative to a Medicare supplement and Part D, which we've already talked about. They are plans that are approved by Medicare, but are administered by private companies like Humana, United Healthcare, Aetna. And these companies provide Medicare Part A and B covered services within their plans, and some include drug coverage as well. When Medicare beneficiaries join a Medicare Advantage plan, you are opting out of original Medicare, and you are enrolling in a managed care product with its various restrictions. The carrier administering your plan sets those benefits and the restrictions. Often there is an additional premium associated with an Advantage plan, but not always. There are zero premium plans offered as well. Now, if you look at this chart, there are many different Medicare Advantage plan product options, including HMO and PPO plans, which many of us know from just being on group insurance. But there's also fee-for-service plans, special needs plans, and medical savings plans as well. Again, with Medicare Advantage plans, you'll see mainly HMO and PPO products. A Medicare Advantage plan covers additional services that original Medicare does not, which is what you'll hear in all that marketing, especially this time of year. They cover dental and vision and have a hearing care benefit, transportation benefits, fitness benefits, which I think we all can agree are great. That's a great part of a Medicare Advantage plan, but you have to remember the restrictions that come with these plans as well. Advantage plans utilize a narrower network than original Medicare for in-network services, which is often based on your geographic location. So that's important to keep in mind. Many plans include prior authorization requirements, referral requirements, and have high out-of-pocket maximums. And these additional requirements often create hassles for the members enrolled in the plans. We can go to the next slide. Okay, so this is a chart you'll see here from 2010 Medicare enrollees to projected 2030, and there has been a huge increase in Medicare Advantage enrollees over the years. And to date, there are currently more Medicare enrollees enrolled in Advantage plans than on original Medicare. And while there are still many Advantage plans to choose from next year, the marketplace has become quite tumultuous and has led to an estimated 2 million members being terminated from their plans for 2025. Although I just want to note that this does not include retiree group or special needs plans, just individual Medicare enrollees. Plans that are cutting their offerings are mainly Humana, United Healthcare, and Aetna. And this is all in an effort to reduce costs. For those whose plans are terminating, the members have to actively enroll in a new plan. Some are being transitioned into new Advantage plans, and many are being put back into original Medicare. So it's important to keep an eye on your mail this time of year. Know that if your Advantage plan is terminated, that gives you a guaranteed issue right to enroll in a Medicare supplement, which is very important for those that live in states that have those restrictions. If you contrast this number of 2 million members being terminated to this year 230,000 members were terminated. So it's a huge shift to next year with plans trying to figure out ways to reduce their costs. We can go to the next slide. Okay, so I want to show you some actual state environments. And this slide here is a screenshot of the tool Sarah just walked us through. It's the Medicare.gov tool, which you can use to run Part D reviews, but you can also use this tool to review your Medicare Advantage plan options as well. If you look here, you're seeing more of a shift in New York than in Connecticut, while in both states, fewer Advantage plans are being offered next year. But in New York, there was a larger number that left the market. So we just picked New York for this example. And this is a New York City zip code. And if you look at the top right, although it's very small, you will see that there are 40 Medicare Advantage plans being offered next year. So I think while we can all agree choice is good, sometimes too much choice is not a good thing. It just makes things more complex. So a few items to note on this screen. First, you'll see those plan benefits on the right, vision, dental, hearing, telehealth, all that good stuff. And then in the bottom left, I want to direct you all to the out-of-pocket maximum. And you'll see those are big numbers. So how that works is your out-of-pocket maximum is the number, the total amount you pay out of pocket before a plan kicks in and pays the remaining 100% for in-network services. So it's $14,000 that the member is responsible for in and out of network services with an Advantage plan, with this plan. And then it's $8,900 in network for in-network services that you're responsible for. And this is only medical. So we're not even talking about prescription drugs. That's an entirely different benefit within these plans that you're also responsible for. We know the cap next year will be $2,000. So keep that in mind, but that's just, the cost of these plans can just be quite high. And we just want people to understand that, because if you're using a lot of services, that's important. Okay, you can go to the next slide. Okay, so there are, of course, changes to Medicare Advantage plan structures for 2025. And plans are increasing premiums, deductibles, copays, all that for next year. The drug deductible for most of these plans will be 4 times higher than it was in 2024. And we just wanted to pick this slide, just totally random Medicare Advantage plan we picked here to show you the in-network versus out-of-network benefits. So the most sort of stark number here is the inpatient hospital care benefit. So if you are out of network at the hospital, you will pay 50% of the cost per day for a limited amount of days, which could be a huge number if you are hospitalized for quite a bit of time. So that's just, again, we're just trying to educate everyone to be looking at these things when reviewing their plans. Okay, next slide. Okay. So we recommend confirming your specific doctor and hospital information if they are in network directly with the provider and with the insurance carrier directly. We don't want you relying on the Medicare tool in this instance. The Medicare tool is fantastic for reviewing your drug coverage within a Medicare plan, but it does not show you whether or not your provider is in network, which is very important. So this is just a printout from the Memorial Sloan Kettering insurance page, and it shows which Medicare Advantage plans they are in network with. So you'll see here, there's 7 listed, but the first and the last are actually New York City retiree plans. So we can't include those. So that leaves 5 carriers that Sloan Kettering is in network with currently. And when Sarah and I were looking at this, you know, it's important to notice that United Healthcare is not listed on here, which was surprising because they are such a dominant carrier in the Medicare Advantage plan field. So again, just so important to be confirming whether or not you're in network with the plan and you're with the plan and the doctor and hospital director. Okay, next slide. Okay, Medicare Advantage takeaways. Even with a reduction in plan offerings, there are still just too many choices to evaluate and compare. Be diligent in reviewing benefit changes and networks. As we mentioned, plans are changing for 2025. You know, one item I really like is an annual notice of changes that members get in the mail. And that's an actual side-by-side comparison of your 24 versus 25 benefits. So that's a great, you know, document to be looking at. Review your benefits through the MyMedicare.gov tool, but also check your providers elsewhere with the carrier and the provider. And then Maura touched on this ever so briefly in her introduction, but what I have focused on today is Medicare Advantage plans in the individual market. So if you have an Advantage plan through retiree, oftentimes those plans are richer than what you would have in the individual market. So just something to make a note of. And lastly, if your Advantage plan is being terminated, you have a guaranteed issue right to purchase a Medicare supplement for that time frame. And not so lastly, as Sarah mentioned, December 7th is the deadline to be making these changes. So we just, you know, that's about 3 weeks away. So just something we wanted to reiterate, to just take a look before then. And that is it for me. I will now turn it back over to Maura to discuss some recent events.
All right, next slide, please. For those of you who would like additional information, here are some resources. The New York Times article, was one of the tip-offs about this demonstration program, which is the subsidies to the Part D. Now, interestingly enough, the article refers to the demonstration program as savvy, and I think some would question that from a healthcare point of view, maybe savvy from a political point of view, not having increases in premiums right before a national election. But I think just looking at the titles of these articles gives you a sense of the turmoil in the environment. So let's move on to open it up to Q&A.
Okay, thanks, Maura, and thanks everyone for a great presentation. We do have a couple of questions that have entered the chat. The first one being in reference to the new $2,000 out-of-pocket maximum for next year for Part D. And this member from North Carolina asks, will the $2,000 Part D max be indexed by income?
Do you want me to take the first one?
Sure, that'd be great.
Okay. So, no, the answer is no. I mean, there's extra help, right? So for people who are under a certain income threshold, there's an extra help program that has I'm not going to say always been there, but for a very long time. And also a lot of people who are dually eligible, meaning if someone's on Medicare and Medicaid, those folks get additional help with their Part D co-insurance of what they pay. But for any middle income person and up, there's no additional assistance with that.
Okay, great. Thank you, Sarah. Our next question is there an out-of-pocket max for original Medicare A and B from Washington State?
I will take that. No, there is no out-of-pocket max for Part B of Medicare. There never has been. Most people, however, have essentially an out-of-pocket max because they've joined an Advantage plan that has one. You know, again, Eileen's example, they can be quite high, like the $13,900. But you also essentially acquire an out-of-pocket max for A and B when you buy a Medicare supplement, except for Plan N, which, you know, you can have unlimited small co-payments, but the others have a maximum. I don't want to talk about Part A tonight. Part A is people don't even understand how the hospital benefit is structured. But again, if you're in original Medicare and buy a supplement, you acquire a catastrophic hospitalization benefit. And that's another, Sarah used the term rabbit hole. There was a Medicare catastrophic hospitalization benefit in the late 80s, but it was repealed. So it is very ironic that the Affordable Care Act came along and in 2014 made ACA compliant plans have unlimited hospital benefits, but that doesn't apply to Medicare. But that's why you shouldn't just have original Medicare by itself. You either want to add a supplement to that or you want to enroll in an Advantage plan. Sorry. Long.
Okay, great. Thanks, Maura. Okay, this next question is I'm going to tee up a very hot question for my group. You're going to clamor to answer this one. Other than offering dental, vision, or hearing, why would I want to get Medicare Advantage versus basic Medicare?
I can take that. I can take that.
Maura, I know you would love to take this one.
No. I mean, I spent so many years of my life discussing this. I for the crowd tonight, what you would want to ask yourself is, original Medicare gives you a national provider network, and you can go to any hospital in the country you choose. If you're the kind of person who, when you're diagnosed with a serious illness, wants to get a second opinion wherever you want to go. I mean, Eileen's example was perfect. And you know, the Mayo Clinic doesn't take all Advantage plans. Even if you have an out-of-network benefit, they just say, we don't want to see you. And Eileen presented that in a kinder way with her Sloan Kettering slide. And I'm not anti-Advantage plan. My mother was a 40-year member of Kaiser Permanente. I am a former Kaiser Permanente executive. But those kinds of systems with a narrower network and more restrictions aren't for everybody. So that's the question. How much if I value choice, that moves me in a direction of staying in original Medicare. And when you're shopping for an Advantage plan, be very, very careful about the fine print, because, you know, they can say they're covering dental. And when you read the fine print, it's a couple of cleanings a year. So keep all that in mind.
Okay, the final question, thank you, Maura. The final question may have been answered, in your, in this last, answer that you gave, Maura, already, but is an Advantage plan the same as a supplement? So no, they are two separate things. The Advantage plan we've been talking about is sometimes referred to as Part C, and the supplement goes along with original Medicare. I think that's been made clear through our discussion thus far, but if not, just enter in the chat if you still need clarification. And in the meantime, we do have another question. Would the Mayo Clinic take a supplement plan?
I can take this if you want.
Yes, Eileen.
Every hospital in the US accepts Medicare. If you have a supplement that supplements Medicare, you were fine. They will accept your plan. It's really when you get into the Advantage plans that you need to worry about the network.
Okay, good. Thanks, Eileen. With
Well,
for questions at the moment.
I do want to say we have Susan Brucey, who's a registered pharmacist, on with us. And if anyone has a pharmacy related question, I know Susan would like to answer.
She's your gal.
Speak now. Yeah. Okay.
Okay, here's
Oh, that's a
one.
good question.
Yeah, I spend 6 months of the year out of the US. Do any of these plans cover me while I'm out of the US?
Shall I? I will.
Yes, Sarah.
So, yes and no. So most Medicare supplements, let me back up. Original Medicare doesn't pay for services outside of the United States. Most supplements have a $50,000 lifetime foreign travel emergency benefit, right? Which if you needed a medical evacuation, that's not going to be nearly enough. And you would have to pay out of your pocket and then submit the claim. I do see a lot of Advantage plans that say they have global coverage. How those exactly work with those plans, I'm not sure. But for our clients who have original Medicare and are spending any time outside of the country, we're always recommending that they buy a standalone travel insurance policy, especially one that's going to pay as primary, meaning the hope is that that travel insurance plan is going to pay the claim directly to the hospital. You are not the one paying them and then trying to get reimbursement from your travel insurance plan.
Let me just add here that there are rare occasions where Medicare supposedly will pay a claim outside the US, but they're really not worth remembering. They're, you're on the border, on the Canadian border, and you have a serious medical incident and their hospital is closer than the US hospital. So just put that out of your mind. Because in all the years I've been doing this, I've never seen those situations. There's another one where the cruise ship has left the port, and if it's within, oh my gosh, let's not even go there. If you leave the United States, please get travel coverage, even if you've got that $50,000 Sarah's talking about.
Okay, thanks, Maura. We just have another question that popped up from a member in North Carolina who says, we get very expensive drugs in Canada rather than filling the prescriptions here. Does that impact the insurance and the $2,000 cap?
Susan, do you want to take that one, or Susan or Sarah?
Okay, I will. No, it does not. Right. So what they're looking at for the $2,000 cap is prescriptions filled in the United States. Most drug plans, especially Medicare drug plans, don't have an out-of-network pharmacy benefit. right? So you really couldn't do anything with that. No, that would just be filled totally outside of insurance, which in the same vein, if somebody is prescribed a medication that's not covered under the Medicare drug program, or maybe is, but it's inexpensive and you don't want to jump through the hoops. If you're going to use something like GoodRx, or any other sort of coupon program, you can do that as somebody that has Medicare. It's just that using your GoodRx coupon or whatever else, using your insurance are totally mutually exclusive things, right? So if you do have a medication that's not covered, and a GoodRx coupon makes sense for you, you can go ahead and do that.
Okay, thanks, Sarah. Another question has popped in. To clarify, you say that all hospitals accept basic Medicare. However, not all doctors associated with those hospitals accept Medicare. Is this true? And would a supplemental or an advantage plan offer me more choice?
Let me take that because I know that's a question from New York. 97% of doctors in the US have a relationship with Medicare. The 3% who have opted out vary very much by geography and specialty. And Manhattan is one of those areas where you've got a large number of doctors opting out of Medicare. The supplement does not pay unless original Medicare pays. So that doesn't help you. And in New York, it's particularly a problem with doctors from the hospital for special surgery. Other major medical centers, you find that everyone generally takes Medicare. The Advantage plan, out-of-network benefit, can of course, reimburse you for a doctor who opts out of Medicare, but it's generally a very, very small amount. Do you want to comment on that, Eileen?
Sure. There are certain Advantage plans that have out-of-network benefits where you can submit opt-out doctor claims, or doctors that have opted out, their claims to your Medicare Advantage plan. And they are processed by, well, some Advantage plans to our knowledge, but it's pennies on the dollar. It's so low. It's not a substantial benefit like if you were on a group plan and having an out-of-network benefit. When a doctor opts out of Medicare on an Advantage plan, there's just not a huge benefit there, but they may pay something.
So in summary, often with those doctors, you have to either pay them what they want or negotiate with them. But Medicare is not going to pay, and the supplement is not going to pay for a doctor who opted out.
Okay, thank you so much. Moving on to the next question, again about drugs. Are all drugs required to be covered by some plan? From looking at Medicare website, it looks like one of my drugs will only be covered by one insurance company. Maybe Susan, you could take that one.
Yes, I unmuted just for that purpose. No, the plans do not have to cover every medication. They have a formulary team that is made up of mostly pharmacists, that they will determine what drugs should be added and deleted from their formulary every year. And there may be a reason why a certain medication, maybe it's too new, or it's a long-acting drug, or it's investigative for a certain indication, medical indication. So they do not have, every plan doesn't have to cover every drug, or every drug doesn't have to be covered by at least one plan. So that's where prior authorizations and formulary exceptions come into place. But you should do due diligence to look at the chart that Sarah had brought up to see what the limitations are and what you'll have to do before you can get the prescription filled by any plan.
Great. Thank you, Susan. We have another great question from North Carolina. Do all supplemental plans have to be written in the state of primary residence, or are some transferable if you move? Sarah, why don't you take that one?
Sure. Yeah, the supplement needs to be written in your state of residence. And generally, most supplements are portable. So portability is the term referring to if you're moving, you can take the plan with you, right? So if you're shopping for a Medicare supplement, it is very important, especially if you have any plans to move, that you're buying something portable, right? Because usually when people are enrolling in a supplement, they're doing that during their guaranteed issue period, which when you go on Medicare Part B is 6 months. So you have 6 months to get into a Medicare supplement, no medical questions asked, right? So you want to make sure that if later on you have a pre-existing condition or you've had a diagnosis and you're moving, that the only thing you need to do is pick up the phone and call the supplement and tell them, hey, I've moved here. They're going to update your premium to match whatever the Department of Insurance in that state has accepted for rates there, right? But your plan should be able to move with you. Most plans are portable, but again, some aren't. So you need to verify that.
You know what? I just like to jump in here because we've got so many questions about supplements and we just didn't have time to cover everything. We were trying to focus on changes for 2025. But supplements, for many years, there were 10 plans, A through J, and there was a lot of stability. That's still too many plans. You know, Massachusetts has a federal waiver. They always offered 2 plans. Nobody needs a choice of 10 plans. But anyway, so the point is you can buy a very rich supplement that covers almost everything, or you can buy a plan with a higher deductible, which the coverage may not kick in unless you have significant surgery or a hospitalization, for example. So today, it's still, I think too many choices, but the system changes. Supplements used to have drug coverage in several of them. That was removed after Part D. You know, so again, this changes. So don't think of supplements as just a single category of coverage. You have choices of products and choices of companies.
Okay, great. Thanks, Maura. I'm going to skip around just a little bit because this is a question that we hear a lot. Is a dental surgeon covered by Medicare or a supplement plan, or do you need to have an Advantage plan that covers dental?
Do you want me to take that?
Or I can,
Yes,
but
please.
yeah.
You know what? The dental coverage you're going to find in an Advantage plan is not going to cover something like major dental surgery. The only time original Medicare covers dental is when the issue is so significant, you have to be in the hospital to have it done. So, you know, dental coverage is largely a benefit of employment, or you buy it as an individual. And the typical coverage through an Advantage plan is much more limited, but that's why we advise read the fine print. So you're not surprised by the benefit. You're not surprised by being forced to use a network person. But original Medicare does have its disappointments. And although it's gotten better and better and better, as one of my first slides said, but it doesn't cover routine dental and vision.
But just to add to that, you can buy an individual standalone dental plan, and many carriers offer those. So that's a better alternative for those who are not on an Advantage plan to have some type of dental coverage, if they want.
Right.
Yes, sure.
The benefit is usually fairly limited. Right, $1,500 a year would be typical. Yeah.
Okay, great. Thank you. I know that's a question that we hear all the time about dental coverage. And then finally, a question a little more specific to a personal situation. I received a Medicare premium letter, but this seems different than the letter of comparison you mentioned. Does everyone receive a letter of comparison? And what again is the comparison?
And I think that's to what I referred to. Everybody on a Part D and Medicare Advantage plan should receive what's called an annual notice of change, which is just what your plan was this year versus what it was for 2025. So if you didn't get it in the mail, it's typically on your plan website. But it's not in relation to premiums, although those should be included, but it's really a benefit comparison to see side by side, year by year. So if you didn't get in the mail, I would check your plan website as well.
Okay, great. Thanks, Eileen. And yeah, I hope we have addressed all of your questions and concerns. If there's still something you're unclear about, please just go ahead and mention in the chat what you want clarification on. I think we have covered just about everything that members have asked at this point.
All right,
yeah.
and we're over the hour, so let me just say to whoever is still hanging on with us, we're going to work on converting these slides to a PDF and getting them on our website, which is healthcarenavigation.com, under the education tab. We will also send that information out to all of you who registered with the recording. And we're very honored to have so many people from all over, especially a critical mass from North Carolina, I guess, join us this evening. So thank you, and thank you to all my talented staff for putting this together.
Great. Thank you, everybody.
Have a great night.
Thank you, everyone.
Great night, everyone. Thank you,
Thank
Maura.
you very
Bye.
much.
Okay.
Bye.
Bye-bye.